Okay, chapter 16 is care of the postoperative patient. So again, well, this is going to be a lot of repeat stuff, but with this postoperative period begins with the completion of surgery and transfer to the PACU. PACU stands for Post Anesthesia Care Unit, or AKA is what that's supposed to say, recovery room. Nurses complete ongoing evaluation and stabilizations of patients in this area. And one thing your book talked about specifically is that the anesthesia provider and the circulating nurse accompany patients from surgery to the PACU to give the nurse a handoff report. It said that during that handoff report, it's that the nurse that's receiving report from the PACU is able to ask or like kind of give a report back to make sure that there's understanding. So, that's kind of like when we talked in Pharm about nurses having the right to be able to stop and think. Like in the same thing here for this handoff report, the nurse has the right to complete information. The PACU nurse, skilled in care of patients with multiple medical and surgical problems, and then you can see the in-depth knowledge that they have. Able to make quick decisions and works closely with anesthesiologists and surgeons is what that says at the bottom there. You're able to print these off. They're all posted on your thing. I'm not really sure why this ended up bigger than my screen for recording. So patients in the PACU, post-surgical patients are at risk for pneumonia shock, cardiac arrest, clotting, DVT, PE, GI bleeding. Obviously that clotting goes into the creation of a deep vein thrombosis, and that can lead to a PE, or PE can just result without one. But there are a lot more risk for other things so they have to be monitored much more closely, obviously. And so I know the nurse to patient ratios in those areas are quite low. So these next few slides are going to talk about the different body systems that were important that your book talked about the post surgical patient. So, there's a couple different pointers here, and then you can see under rate, pattern, depth of breathing, a respiratory rate of 10 or less can indicate. Okay, so the dog started barking. I think you heard some of that, so I'm going to continue, and hopefully this picked up where it left off. So again, the rate, pattern, depth of breathing, the respiratory rate of 10 or less can indicate anesthetic or opioid-induced respiratory depression. So this is where we would end up potentially using Narcan, like we were talking about in class today, if it were severe, if it was causing ineffective airway, gas exchange. Another thing that we're going to be monitoring for a lot is breath sounds. A couple things your books mentioned and pointed out was smokers and obese patients at higher risk of respiratory complications and need more frequent assessments. So we have to make sure that we get a good assessment prior to make sure we find out if our patients are smokers, how long they smoke, how much they smoke, because all that's going to play into how well they're going to recover in the post or in the PACU afterwards from being intubated and being sedated. Respiratory continued, we're going to be watching our patient for sternal retractions or diaphragmatic breathing, so accessory muscle use, snoring and stridor. So this YouTube video, I'm not going to play it right here for you, but when you print this up not print it up, but when you open this up, it's under the weekly folders for week 1. You can click on that. It's I think it's 1:57. A guy on YouTube put this thing together and he kind of demonstrates what stridor sounds like if you don't know what that sounds like. And there's other YouTube videos that can actually, that show, or not show, but demonstrate the sound of what stridor sounds like. So your patient in the in the PACU is going to have stridor because of maybe some type of damage that happened, and so there's swelling, that's inflammation that's happening in the airways or in the trachea. Respiratory depression or hypoxemia, if the patient's oxygen sats drop below 95% or below the patient's baseline, we are to notify surgeon or anesthesia provider, okay? Because that's obviously an indication that the patient is not recovering as well as we would like them to with their respiratory status. So cardiovascular assessment, vital signs are every 15 minutes until the patient is stable, and then we report significant changes, is what that should say, in blood pressure. Your book says 25% difference of baseline. We monitor heart sounds, cardiac monitoring, so bradycardia could be an anesthetic issue or hypothermia, peripheral vascular assessment. So again, we're monitoring for a deep vein thrombosis or a PE. Pulse deficit was something that also was mentioned, and one of the bolded words in your book. That is a difference between apical and peripheral pulse. So if my apical pulse, which is what I'm listening with my stethoscope, is different from my peripheral pulse, this can indicate that the patient has a dysrhythmia. So we're going to want to get them hooked up to an EKG and see what's going on with them. So it's just important for you to, if you end up in those areas, but in all areas, especially if you're dealing with a patient after surgery, that you're monitoring for those things. Neurological system, so level of consciousness or awareness, that's what that says under my blue brain there. Asking questions like, what is your name, where are you, what day is it? So these are questions that we ask a lot of patients in the hospital to determine their level of consciousness. Motor and sensory assessment after an epidural or spinal anesthesia. So basically what that is saying is that they want to make sure that the patient can feel and the patient can move their own legs before they'll leave the PACU. So page 261, chart 16.3 is recognizing serious complications of spinal and epidural anesthesia, and I want you guys to make sure that you go over those and read those. Fluid, electrolyte, and acid base, you can read that stuff for yourself. Much of it is self-explanatory. You should have read that or will read that in your book as well. But, you know, to know that it's important, especially those I's and O's that we're watching, and a lot of O's that we normally don't think of. So urine output is obviously our big one, but if people are vomiting, if we're doing drainage from wounds, nasogastric tube drainage, that's all going to count for the output. So we have to make sure that we put all that stuff together when we're watching that. The renal urinary system, you want to check for urine retention. So there's many preoperative medications that can cause retention, and it's very common that this will happen for the patient afterwards. So a lot of times they may need straight cath for that first 24 hours. Remember, again, consider those other sources of output, which I just talked about, and we report urine output of 30 or less than 30 mLs per hour. So that's pretty standard in all areas of nursing. Gastrointestinal system, so nausea and vomiting are very common afterwards. Your book said 30% of patients will experience that after anesthesia. Peristalsis may be delayed up to 24 hours. So peristalsis is the movement of basically our bowels, like our GI system, the intestines. And so that can be basically like, you know, it's gone into not paralytic state, but it's kind of like in the show, you know, it was depressed as well. We kind of turned it off with that anesthesia. So it can take up to 24 hours for peristalsis to start back up. But on top of it, we're giving them pain medications like opioid pain medication, which causes constipation. So between lack of peristalsis and giving medications that can do that, constipation ends up being a huge thing too afterwards. So we're definitely monitoring for bowel sounds. And as you hopefully learned in your fundamentals, that can be listening all the way up to 5 minutes to listen for bowel sounds. Your book also talked about sometimes that bowel sounds aren't the best measure for the post-surgical patient, that sometimes it's more if they're actually passing gas is a better determinant of that. So, but both things we're definitely going to be charting on. And then so you've got some medications below there that can reduce nausea, vomiting. Zofran is obviously the most popular for that. The other meds there can help with like dizziness and things of that nature. Some people it works for nausea, vomiting too. But Zofran is probably the one I see most common in all areas, both when I worked in the hospital and working at Brighton. So NG tube drainage, different things that those are inserted for. We talked about a little bit about that today. And so I've got a list here for those. You guys can read those. We're assessing the drain material every 8 hours. And then colors, I wanted to list for you because it's important that we know what's a normal color. So greenish yellow is a normal color of the fluid or the drainage that we're getting from the stomach. Red or pink is indicates active bleeding, and brown liquid or coffee ground indicates old bleeding. So it's important if you see a change or that's your initial that you get that we're reporting that, because the only one that's normal is greenish yellow, but definitely if it's a change and that was not given to you upon the report. So skin assessment, normal wound healing, read page 264. It's got a lot of good information about wound healing, and it's very important for us to understand the skin and healing. So 264 is something I definitely want you guys to make sure you've read. Impaired wound healing is seen most often between 5 and 10 days after surgery. So these next two words you're definitely going to want to know, dehiscence and evisceration. We're going to look at a picture of it in just a second, but dehiscence is partial or complete separation of the outer wound layers, and evisceration is the total separation of all wound layers and the protrusion of internal organs through the open wound. This is considered a surgical emergency. And so that's what that looks like right here. You can see in the upper part right here, that's what a dehiscence would look like by itself. And then the evisceration is the actual internal organs that are coming out of the body. Your book actually goes through pretty well what a nurse should do in the event that these things happen. And I think it's very important that you guys go through and read that. Oops. So physical and emotional signs of pain. That you can go through that right there. So in the patient that's confused or a patient that has dementia, down here towards the bottom, you're going to see more of like restlessness, confusion, wincing, moaning, crying, patients that can't communicate verbally. Definitely these last three, and we'll talk about that more in Med-Surg 2 when we get there. Laboratory assessments, different things we're going to be watching, especially if they've got an NG that we're pulling out, gastric contents and that we're going to be throwing off electrolytes, and just surgical and overloading with fluid and everything already causes that. But when we're watching our CBC and differentials, if we see this thing, what's called a left shift, is also called bandemia, and band cells are immature neutrophils. So neutrophils are going to go and try to fight infection eventually. But when we see this immature ones, they don't really do a whole lot. But when we find them, we know that we've got infection coming. So we take, culture and sensitivity. That's that next one of different areas from where the infection can be. Doc's going to start some kind of antibiotics. And then I just kind of listed some other here, but the primary thing on here that you're concerned with is that left shift and what that indicates. So potential for hypoxemia, the highest incident occurs on the second postoperative day. Different things that nurses can do in order to prevent this or help with this, not happening is making sure we keep a patent airway. We're watching the SpO2. Semi-Fowler's position, actually your book talked about, this is a position that all patients, unless contraindicated, should be placed in after surgery. Oxygen, breathing exercises, and moving as soon as possible. The book also stressed that even with very serious surgeries, that many docs want their patients up that later that day or early the next day, that we want people moving ASAP. There's not a bunch of laying around after surgery anymore like there used to be way back. So more stuff on wounds. You got some nursing assessment stuff. We're talking about dressings here. The first change of the dressing is typically done by the surgeon, and then we typically get orders for how they want us to change those dressings. Drains, we're going to be managing those drains and what's coming out of them and checking on them, and emptying them. You got some interventions. With the second one, debridement, that's going to be for a wound that hasn't been healing well, and same thing with surgical management required for wound opening. Like there's different backs and stuff that we use, and we can talk more about that at another time for that stuff. Pain interventions, so drug therapy, chart 16.7 on page 270. Make sure you go through that chart and read up on PCA delivery systems on page 269. And remember, we have other things besides pain medication that we can use, such as positioning, massage, relaxation, diversion techniques. Your book went through about a list of 7 or 8 things that they talked about of different things that we can use for pain interventions. So that is it. And again, enjoy your guys' weekend, and I will see you all on Monday.